This is the DocNation podcast. We are a movement founded by doctors, for doctors, dedicated to empowering medical professionals to reclaim control over healthcare decisions and advocating for their fair share of the industry's resources. Please note, the views expressed are those of DocNation and not necessarily those of our guests or referenced health centers. Well, today we're talking with Dr. Winslow Murdoch, a family physician who's been at the front lines of medicine for over 35 years. He started as a solo practitioner, built a thriving multi-physician practice, and then made the jump to direct primary care, long before it was a movement that it is today. Beyond patient care, Dr. Murdoch has been a relentless advocate for physicians, serving a longtime delegate with the Pennsylvania Medical Society and pushing for real change in healthcare policy. He's also been at the forefront of medical innovation, mentoring doctors at point-of-care ultrasound, and even using AI to make the electronic medical records systems more efficient. Named one of America's top family doctors and a regular on Philadelphia Magazine's Best of Philadelphia list, Dr. Murdoch has a wealth of experience and insight into the future of independent practice. Dr. Murdoch, you've seen firsthand how primary care has changed over the years. Where do you think it's headed next?
Well, I think we're at a crossroads where I think there'll be a splitting up of how we approach primary care in the community. I think for young, healthy people who really don't need a lot of healthcare services, they're more acute related problems. I think the existing programs that we have, where it's not necessarily relationship based, but it's problem based, will continue. And we'll see an expansion of advanced practice practitioners filling in that role, and there will be more and more integrated urgent care type issues for the community. But for people that develop three-dimensional healthcare problems, I think we are going to see a dramatic change in how we deliver that primary care to the community, to have a medical home for those people who otherwise are cannot be managed properly with the existing systems.
Really quick, relationship-based versus problem-based. Tell me with that.
So again, for somebody that's young and healthy and doesn't have three-dimensional healthcare issues, they're looking for problem solutions that are quick, efficient, busy lives. They're looking for quick care, and they can get that through the existing systems of how we deliver primary care in this country. But again, with more complicated patients, we need a different system to manage those people, to really be their medical friend and their ally.
Goes back to that patient-doctor relationship, the relationship that's been strained, and that there's been a huge divide. It used to be like this, and it's gotten to be like this with so many other parties involved in the process, and patients don't really know where else to look to see what the cause of the problem is, except for the person that they're closest to, which is oftentimes is you. You've been working in the direct primary care and other ways of doing things differently with your practice. Tell us about what life looks like for you on a weekly or monthly basis.
Again, people think if you're doing a lower patient number of care that you provide for your population, you're going to have a less busy job. But that's not really true. It depends on how hard you lean in and how much the patients rely on you as their medical friend connector for the rest of the healthcare system. So, it's a full-time job. It's not the grass is not always greener from an actual hours committed to patient care. But the amount of things that you can do, the value you can bring to the equation is dramatically different. So I'll typically spend 4 or 5 hours with a new patient, not face to face, but going through their medical records, pulling together information, trying to put together a long-term game plan and medication simplification or correction, if you will. A lot of people, it's low-lying fruit for new patients that come in that are complicated, because 9 times out of 10, I'll find dramatic drug interactions or mistakes that are being made that are really changing the patient's life trajectory when I make those in the first couple of visits. But there's a big commitment of time to kind of put the pieces together that really traditionally is not allowed in a traditional primary care environment. That's a big difference in what we do. And then when ongoing care, usually half an hour to 45-minute visits for follow-up. Some people, it takes a half an hour just to vet their medication list on a follow-up visit, because they don't know what they're doing. They have multiple specialists that are changing things. And you really have a lot of knots to untie to really get down to what's important for them.
It's a great visual, that rope with all kinds of knots in it. that you're trying to undo. And then once it gets pulled so tight, it's like it gets really hard. You got to rip your fingernails off a little bit just to get that thing undone to get it
Yeah,
opened up.
absolutely. And then the relationship, I don't necessarily appreciate this in the moment, but when people recognize that I care enough to do that when they come in for each of their visits, they're much more likely to tell me what's going on or where they're having a problem, and to lean on our team, not just me, but my office team. I have a full-time front office person who is the coordinator and a clinical liaison who helps with drawing bloods and takes care of a super high risk population of people with regular contacts to keep them out of trouble. So they're an important part of the team as well. And people look at us as part of their family. We're extended family.
I'm jealous.
Yeah.
Yeah,
I'm not getting that care.
no, no.
No.
Again, if you've seen one direct primary care practice, you've seen one. So we all have our priorities and strengths. We have things we're interested in and things we lean into as priorities. And I just, have found a niche for this population that I'm primarily managing.
I don't feel like I don't want to be dramatic or maybe I should
Do
be
it.
dramatic here with this,
Yeah.
but so 4 hours, that sounds like great care.
4 to 5. 4 to 5. I'm blown away on that number.
Yeah.
Yeah.
What are people typically getting? Because it's a roll of the dice here. Most people just like, hey, do you know a good doctor? Can I find a doctor? Whatever, and you wind up somewhere where your insurance sends you. What kind of preparation would most people be getting?
Typically, for the larger health systems, they have access to, care everywhere, an Epic related product or link. So they can download, medications that have been filled. They can download whatever diagnoses have been billed for the patient in the last couple of years. They can download bits and pieces of information, but to put it all together and make each of the different diagnoses a cogent story or a couple of paragraphs of how did things start, how things develop, what workup has been done, so that you know when to repeat and when not to repeat. That takes a chunk of time. So typical primary care practice will download what's readily available for them in their EMR. They'll take whatever comes up as working diagnoses, and when you actually go through it, a lot of those things really aren't true, or they were a diagnosis that was to be ruled out, and it was ruled out, but it sort of stays on the patient's list. So I've seen, some people coming in with 70, 80 things on their Epic problem list, and there's a lot of more knots to untie there as well to figure out what's important, what's true, and what's not really accurate.
That's a knot on top of a knot, is what you're
Mhm.
saying.
Yeah.
So
And,
when you say that you've seen one direct primary care, you've seen one. The rest of that phrase is what? What's the normal way that people say that?
If you've seen
well,
one primary care, you've seen them all. If you've seen
Seen them
one,
all.
you've seen them all.
And Dr. Murdoch, you're saying you're seeing one. Can you really maybe tell us why you're saying it that way versus saying you've seen them all? Because clearly they're not the same.
in direct primary care, we all try to invest more time with each of our patients to really provide a value-added service so that we develop patient trust and loyalty that will justify us charging an extra fee that's not through their insurance, and it's out of pocket. Right now, it's, post-tax, or it's not pre-tax money they're paying. Um, but the amount of time and bandwidth that a primary care doctor has and their dedication to lean into getting a patient figured out and the knots undone is going to vary individual to individual. Some people might be very comfortable managing, people with chronic kidney disease and heart failure and a whole host of other things. Other primary care docs might be less comfortable with that, so they rely more on their referral network. Although the patients, if you ask them, they really want to have that primary care medical home that can focus on them and manage most of their care. So it really depends on the bandwidth, the interest and core competencies of the primary care practice, as well as the interest the doctor has and how much trust the patient has in the doctor to manage those things. So it's a three-dimensional chess any way you look at it.
This is super interesting. So what can we do?
Well, right now, there's really not a lot of resources to do intensive direct primary care. There are some individual companies that that work with populations of Medicare and Medicaid patients, such as, some of the Medicare Advantage plans will work with specific companies like ChenMed to manage a higher risk population that maybe has more socioeconomic barriers and hurdles to care. But that doesn't really fit for the whole community. So that's sort of fits a specific population with a limited amount of limited coverage benefits through that Medicare Advantage plan. So I think that if we can find a way to identify patients that are more complex, that require more three-dimensional care, resource primary care, not in the traditional model of fee for service, or inexpensive direct primary care where the patient's, out of pocket is maybe $75 or $100 a month. That's not going to work for this population. This population needs more resources in primary care than that. And that requires some, unique and out of the box thinking to try to build a system where that is supported and becomes sustainable in the community for primary care doctors that want to do that, that they can do that. And that's a whole new, a new horizon.
How do your colleagues respond to you when they are hearing about what you're doing if they're not following in your footsteps or they're not doing something similar? What's the reaction that they give you? Do they think that you're doing something that is so beyond what's possible? Is it like unreachable from their perspective, or are they inspired by it? Are they how do they process what you tell them about what you're doing?
Well, again, if you work in a traditional model that accepts insurance, what we do at our office is you can't do it. I mean, you don't have the resource of time to really coordinate. Even if you had an army of, social workers and nurses and what have you, you don't have the time to really build that relationship and dedicate yourself to really knowing that patient inside and out. So it's always more transactional in that kind of an environment.
Mhm.
In other doctors that are doing direct primary care, right now, because their reimbursement model is generally $100 a month or less, they don't really have the resource if their practice is growing rapidly and they're starting to fill up their panel to have 4, 5, 600 patients. They lose the bandwidth to manage this in this way as well. So they think it's interesting. They kind of, oh, you do that too. Oh, you do that too. They're impressed by the breadth of what we can do, especially as we talked about having a point of care ultrasound really lets me extend what I can do from a physical exam diagnostic point of view at the point of care. Again, I don't charge for that. It's just part of my physical exam. But again, a lot of people say, oh, that's cool, but it's just not applicable to the environment that they're working in. So it's an aspiration maybe for some. Other
Yeah.
people just like simple things. You want to take care of if it's going to make you bleed out of your ears to figure out that knot, they'd rather hand that off to somebody else and
Right.
not have to be untangling all that stuff. So it really comes down to the individual and their tenacity to figure those things out.
Dr. Winslow, what got you to the point where you wanted to provide this type of care? Because you could decide not to untie probably a good 60 to 70% of those knots, but you've decided to untie them. What's got you
Yeah.
to this point?
Well, it was sort of an interesting transition. I started off independent, solo, grew to 5 docs, a nurse practitioner, a PA, sold to a healthcare hospital system. The hospital system, after about 5 years, decided to go for RVU-based reimbursement for the doctors, and all my colleagues suddenly wanted to send all their complicated patients to me and just take care of urgent care, same day, simple stuff.
Yeah.
And I realized that wasn't a model that I could survive in. So that's when I branched away. This is back in 2001. We're talking a long time ago. To sort of start this model in its initial stages, and over the 3 or 4 years after that, we kind of built to this model. That's just the way it's been running since.
So filling a need,
Yeah,
basically, is how this got there.
and I tended to collect some of the more complicated patients in my larger practice. So it was a win-win for me, and it was a win-win for my patients at that time making the transition.
We're starting to get more and more patient following and not just physician following at DocNation. Could you explain why, because of the RVU based model, they would send you those more complicated patients?
Right. So typically in a reimbursement for a doctor taking traditional insurance, they're they can schedule different levels of complexity for a visit, but they really, because of the way things are reimbursed, want to simplify what their scope of work is during an office visit. So typically you get paid the most for taking care of one problem. If you now take care of two problems, the multiplier of what you get for the work done is diminished by maybe 50 to 75%. If you take care of three problems, it's diminished even more. So the focus of the clinician is, let's identify what's the most urgent, pressing problem, either medically urgent or to the patient's quality of life urgent, and just focus on that and tell people to come back for a follow-up, come back for a follow-up. But in reality, a lot of these issues that come up and that need to be addressed really feed off of each other and really should be handled all in a longer visit. But traditional insurance doesn't really pay for that cognitive time to figure those things out. It pays for transactions and one problem per visit. So that's not a good model for more complicated patients in the community.
So I have
value.
a lot of
The
friends.
patient needs the patient needs help, and they need help not just in the biggest ticket item that the alignment there. It's just a mismatch. Like
I have a lot of friends who listen to this now. I'm actually getting more friends who listen to this than that's, you know, that's just really picking up. And they're saying, why such a disdain for the insurance companies? And if I could just speak in layman's terms, the doctors don't want to do what you're proposing you think is the best way to do it, because they're not going to get paid to do it. And they have to to feed their family as well. This isn't just a huge money play by the physician to do that. It's, no, if I literally did this over every day, all day, I wouldn't make money. I'm not able to sustain this. So
it's an expensive hobby.
There you go. That's perfect.
It's
That's what this is. We've been reduced to this. The medical profession is an expensive hobby now.
If you want to do a good job and you want to work within the system, it's a very expensive hobby. Yes.
oh wow.
My wife said, I've never heard you say the word hate so much in your life until we start talking about insurance companies and hospital administration. And I said, well, I think I feel that way. I think I really feel that way. There's a genuine hate there because we've taken our highest educated level group of people and said, we're not willing to pay you to keep America healthy. That's what it comes down to. And
people don't realize that, you know, a typical primary care practice overhead is close to $300 an hour without the doctor getting paid a penny. So, you know, and if the insurance is paying, you know, $70 for a visit, that's a lot of visits to cover the overhead before the doctor can walk home with a nickel. So you've got to really change the way you practice and really work within the rules of the system, which aren't helpful for the physician nor the patient.
I've been hearing lately a lot of this about treat this one problem at a time, keep the patient coming back. Doctors talking about algorithms instead of treating everything all at once, and it's concerning the data of patients. It was called conservative care decay, or referral fatigue, and the patients would just stop, just give up.
And if they have a good primary care doc, because the specialists are stuck into the same system. So if they can't figure out in a visit or two what the issue is, they say, well, go back to your primary, and we're left there to cut bait and go back fishing. So, but the primary care docs can really offload a lot of the routine, redundant stuff that specialists do, ease up some of the efforts at the ER, ease up the specialty backlog for real important specialty related care if they have the resource to manage multiple problems per visit and really be a, you know, for people that need it. You know, this is not for everybody with a stub toe or an ingrown toenail or a boil or a sore throat, but this is for the people that really need three-dimensional care, where one decision has knock-on effects on 4 or 5 other conditions they're currently experiencing. So it's a different game, if you will, than traditional care. And right now, most of the responsibility that comes if somebody goes to urgent care, they're not having a response to the therapy that was given. They bounce back to primary care with a much more complicated problem than they initially went in with. That knot has to be untied as well. So it really, we need to really reimagine the way primary care is resourced to have it do the job that it's capable of doing.
I've been working in medicine for a long time now. And I had a conversation 2 days ago with someone in my neighborhood, and it really kind of broke my heart. And he's a very successful, very smart guy. But what he said was, I go on Google and I'll diagnose things myself. And then I have a friend that I'll call and I'll have them go prescribe me something. And I'll go to Walgreens, I'll get my medication. I'm done going to the hospital. I'm done going to see anybody. And I just thought to myself, this is the greatest country on earth. This is the greatest country in the history of civilization, not in terms of what we're able to achieve on a daily basis. We have everything at our fingertips. And to hear that from a really, really educated guy, I thought to myself, man, that's a disappointment. And you're hitting the nail on the head, Dr. Murdoch, with everything you're saying. And there's reasons why. Like, you know, my wife was like, "Oh, I can't believe he said that." I'm like, I can. It makes complete sense to me.
Mm.
He said he bounced from one doctor to the next, 4 doctors in 1 year. And he said, just long story short, it wasn't that they weren't smart. It's just that I could never have a conversation with them. They got me to the point to where I needed to be. And he was mad at them. That's the issue. He was mad at them, not understanding why they have to churn and burn, why he only got 30 minutes with each one of them.
And you know, our time as clinicians is precious, and so trying to find ways to make ourselves more efficient in the day-to-day work that we do is critical. You know, using AI to help with chart notes when you're touching on 4 or 5 different problems with a telemedicine visit or in-office visit, using you know, a smart ordering for labs and having templates, doing things behind the scenes to improve our efficiency lets us have more bandwidth to have the ability to untie more knots. So the more knots that they throw at us through prior authorization and pre-certification and all the other nonsense that goes on, the less knots that we can untie because we're tied up with a lot of that administrative stuff. That doesn't go away in direct primary care because people still have Medicare or a commercial insurance plan that has all those hurdles and administrative things. We just have a little more bandwidth to fight for the patient to get through those hurdles. But again, that's a resource of time that takes away from our ability to handle other things. And that's another reason why patients are getting frustrated because their doctors have less and less resource of time.
How long did it take for you to know that what you did in this last go around? Because you've taken risks, you've pioneered, you've made moves that many doctors have never made and never contemplated making. In this last go around with direct primary care, how long did it take for you to figure out or to realize that this was the right move?
30 seconds. That's that you know, financially, you know, it was you know, disastrous for my family for the first couple of years until we got things up and running properly. But that's, you know, right away I became energized and impassioned to be involved in organized medicine, the medical society, our county medical society. I've been very active with trying to work on these issues from a systemic point of view, not just in my own, you know, day-to-day life. So as soon as I switched to this model, suddenly I'm like, oh my gosh, I've got to share this with other people and get involved and make this the norm 20, 23, 4 years later.
Yeah.
Almost there, right? Almost there. Getting
Yeah.
there.
Oh my
Yeah.
gosh.
But it was worth it. That 2-year struggle phase was worth it in the
Yep.
end. You knew it was right away.
Yep.
Man, thanks so
Well,
much for being on with us,
Yeah,
Dr.
pleasure.
Murdoch. This is exactly what patients need to understand. The trouble here isn't the doctor. It's everything that handicaps and ties the knots and causes doctors' hands to be stuck behind their backs. They're so limited. And Reid, what you said about what your neighbor's having to deal with. I mean,
It turns the patient against the doctor because of the lack of education and understanding, which is an education and an understanding that a patient should never have to have. They shouldn't have to understand RVU rates. They shouldn't have to understand why they're only getting 30 minutes. They should be able to just get that, but they can't get that unless someone like Dr. Murdoch becomes a pioneer. But we shouldn't expect doctors to become pioneers. We should expect doctors to be doctors. So there's too many large inherent problems with healthcare that we've been fighting for years now, and it's not getting better. It's not getting better. So the concern is there, and really the question is how many Dr. Murdochs are going to come out into the public in the next 4 or 5 years, because in the next 4 or 5 years, we're going to see big transitions with AI coming in and taking over certain things in healthcare that are going to be monumental.
It's a fun time, scary but fun, and I'm optimistic. And this is a good way for me, from a full career. This is a good way to have it. I'm 65, maybe 5 more years in the tank, but it's a good way to kind of have things close, with closure of continuity of the model, and knowing that it was the right thing to do from the start was helpful and kind of got me through a lot of rough times. So it's exciting, and thank you so much for having me on.
Thank you, Dr. Murdoch.
For all the work you've done for us. Thank you so much.
Thank you.
Pleasure.
This has been the DocNation podcast. If you like what you heard, be sure to subscribe, rate, and leave us a review on Apple Podcasts, Spotify, or wherever you are listening to us. Your feedback really helps us reach more listeners like you. We'd also love to hear your thoughts and any topics you'd like us to cover in future episodes. Don't forget to follow us on Facebook, Instagram, and LinkedIn for updates, behind-the-scenes content, and to join the conversation. Thanks for listening.